Okay, so now in the next 30 minutes, I will be sharing some expert-guided pearls on techniques focusing on procedures that your millennial patients may likely come in and request. First, a few items of housekeeping. I have no relevant conflict of interest. Off-label applications of products will be discussed. And the colloquial term botox will be used in certain slides referring to neuromodulators in general. And lastly, while I have obtained patient consents for videos and photos, but please respect patient privacy by not taking any screenshots or recording of slides with patient videos and images. So now let's move right ahead into practical pearls. Before I start the technical aspect of the talk, I do want to share with you some tips I have gathered from my own practice, as well as from my colleagues and experts in the field, that there are principles or concepts that can be beneficial for you. First, it's important to recognize beauty is dynamic, it's not static. We're treating patients, not photos. So this is why a lot of times a full facial assessment with patient emotion, when they're emoting, when they're speaking, is very important when you discuss treatment plans. And when we offer treatment plans for our patients, even though they may come in requesting just one procedure, they oftentimes are very appreciative if you spend time to give them a holistic approach, a plan that's take them for the next 2 to 3 years or even 5 years. That is really one of the best ways to retain patients in your practice. And thirdly, it's important to also take time to discuss expectations, risks, and alternatives. And whenever you're performing a procedure, safety should always be a priority. Safety in terms of filler occlusion, avoiding vascular complication, and always be prepared for worst case scenario when you're treating patient, regardless of how simple a procedure may appear. And lastly, when in doubt, when you have any little hesitation, say no. And when you're treating patients, it may be tempting to give in, but at the end of the day, maintaining your balance, maintaining your integrity is very important. And a lot of times, less is more. And I'll be showcasing some examples of my aesthetic patients in the millennial age group, how less is more and how you can optimize your outcome with just a few key procedures and using minimal products. Okay, first, let's talk about popular neuromodulators for the younger patients. So a lot of times your patients may come in with a photo of their favorite celebrity. They may want to say, oh, I want my brow look snatched, or I want to have my eyes bright and open looking like hers. And they may even come in requesting certain procedures such as brow lift, eye shaping botox. And I'm sure a lot of you guys have heard of baby botox. It's not botox for baby, but it really refers to preventative botox. And lastly, lip flip. So these are some of the top 4 common neurotoxin or neuromodulator procedures I see in my practice among the younger patients. So let's start with brow lift. Brow lift really helps to elevate the tail of the brow, give a more open, a brighter appearance of the periorbital area. Here, we're targeting the superior portion of the orbicularis oculi, which protrudes and depresses the lateral brow, especially when patients are squinting or they're smiling. Optimally, when you combine brow lifting Botox or botulinum toxin along with treating the rest of the crow's feet or the orbicularis oculi complex, and we add a treatment with the medial brow depressors, you can have a really nice outcome in terms of brightening and opening up the periorbital area. This is a typical patients coming in requesting for a brow lift. We have barely any, really, she's beautiful to begin with, really not any issue that you can tell, but patients oftentimes are very educated. They may come and say, oh, Dr. So-and-so, I just want my brow to be a little bit more open. I want to look brighter, but I don't want to look frozen. I still want to look myself. So here we targeted the lateral superior portion of the Burkillaris oculi. We treated the rest of her crow's feet and just a very low dose of the glabella complex, but a neuromodulator. As you can see, in 2 to 3 weeks, she has actually a nice elevation of the lateral tail of the eyebrow, about 1 to 2 millimeter difference. And when she smiles, there's even more of opening of her eye aperture because we're treating the depressor lateral portion of the eyebrow. And also, she actually looks still very much herself. So this is what younger patients want. They want to look unchanged, but they want to look fresher. Oftentimes, we combine brow lift with what we call baby Botox or preventative Botox. So here we're dosing a slightly lower quantity of neuromodulator compared to a neuromodulator for older patients. So here patients don't really have much resting rhinitis, but they're noticing a little bit deepening of their crow's feet, maybe deepening their frown lines when they're emoting. So they want to get ahead of the game. So they want to be proactive. So here, by dosing appropriately, targeting the medial brow depressors, targeting the frontalis, as well as orbicularis oculi, we can have a very nice natural result with elevation of the lateral brow, maintaining her overall brow shape, and significant reduction or softening of the crow's feet when she's smiling. And a lot of times, these subtle changes are actually what patients are looking for. They're looking for just a little bit brighter upper face area. As you can see, at resting, there's very minimal difference, but if you look closer, there's a little bit brow lifting. Her eyes just look brighter. So this is a typical outcome of preventative Botox. Along with preventive Botox to treat the medial brow depressor, frontalis brow lift, another procedure is becoming more popular to open up the eye aperture, also known as the jelly roll Botox that you may have heard of. It refers to treating the pretarsal portion of the palpebral part of the orbicularis oculi muscle. Here, we can increase the eye by about 1 millimeter. And this is actually a very popular procedure in Asian patients to have a larger or more westernized eye aperture. For older patients, this procedure is also effective at reducing the horizontal rhinitis. But here we have to be careful. We need to select appropriate patients. Oftentimes, it's important to perform a snap test, make sure patients don't have a lot of scleral show at resting, and definitely screen patients for prior history of blepharoplasty, especially nowadays with younger patients getting invasive procedures earlier. It's just worth your time to ask for a prior history of invasive procedures to avoid complications. In my practice, I find the jelly roll Botox is most optimally combined with under eye filler. So here you can see just 1 to 2 units of Botox or 3 units of Dysport, injecting very superficially to the infrapalpebral portion, slightly lateral to the midline can give you a nice result. And then in some more mature patients, this patient in her late 30s, you may want to start with a full upper face neuromodulator treatment. As you can see, we treat the procerus, corrugators, we treat the frontalis, and a lot of times it's important to adjust your dosing as well as injection pattern based on patients' individual anatomy. So I like to ask patients to emote, squint, frown, smile as I'm injecting to identify where to optimally place your neuromodulator. So here we treated the brows, we treated the frontalis, we treated orbicularis oculi. We did a little bit brow lift. We also did a little bit jelly roll. We also treated bunny's line or nasalis. And it's also important to talk to your patient about what they want. Do they want a soft effect, or do they want a frozen or like a stronger effect? Most patients want a softer effect. So here's a before and after of this patient. As you can see, she has a significant reduction of her glabella lines, and when she smiles, it's a much softer crow's feet, and her brow looks elevated and lifted, not smocking. Lastly, I want to go over a very high demand procedure in younger patients, particularly Gen Z patients. Is called lip flip. So in this study published last year, this graph shows the Google search terms on lip flip. As you can see, it's very interesting. There's a sharp rise in patients searching for lip flip on Google, starting from 2018, and really exponentially increased over a pandemic. And that's why you're hearing more patients coming in requesting lip flip. So in this procedure, you can give patients a very subtle enhancement with the contour, eversion, and fullness of the lip volume by targeting the superficial orbicularis oris muscle at the vermilion border. Here, you really want to inject very superficially to avoid elongation of the upper cutaneous lips. And also, it's important to talk to your patient about expectation. When it's done right, it gives a subtle enhancement of the upper or lower lip volume. But when we do too much of the lip flip, patient may have problem with oral continence. So they may notice not able to drink out of the straw. So you may need to talk to your patient about what to expect after lip flip Botox. This very subtle before and after illustrates what a lot of the younger patients want. So she is in her mid-20s. She comes in wanting to have a glow up before the wedding. So as you can see, she's beautiful to begin with, and she just wants to look fresher for her wedding day. We did a brow shaping Botox. You can see the lateral brows a little bit more lifted. It's more open medially. We did a little bit jelly roll Botox to open up her eye aperture. We did a little bit lip flip. There's a subtle enhancement of upper lip projection volume. So even though these are subtle changes, patients are often very happy with these subtle changes, and that's all they want. And when you combine neuromodulators with other procedures such as biostimulator, in this case, PLLA for temple, and under eye filler, you can actually very effectively rejuvenate the whole upper face area over time with these minimally invasive procedure. So now we're going to go right ahead into dermal filler procedure pearls for the millennial and Gen Z patients. I want to spend just a couple of minutes to touch upon a filler complication. So this is really a subject that deserves a whole seminar, but because of time restriction, we're just going to go over some of the most a feared outcome as aesthetic injector, which is occlusion or vascular complication from filler. It has been estimated that tissue necrosis occurs maybe at 8.5% of all filler injection. And as injectors, our worst nightmare is really ocular blindness secondary to occlusion of the central retinal artery. Here, mechanistically, we typically have a intravascular injection of the filler material into either supratrochlear, supraorbital, angular, or dorsal nasal arteries that eventually lead to retrograde embolization of the filler material into the ophthalmic artery system, leading to blindness. In this more recent update on worldwide literature on blindness induced by filler, published 2019, was found of the 48 cases of blindness since 2015, the top area for filler-induced blindness or nose injection, so liquid rhinoplasty, followed by glabella region, which is very popular in Asia, in and for Asian patients, and forehead, and followed by nasolabial fold and temple and infraorbital injections. Really, when you look at facial anatomy, Dr. Laurence already went over with you earlier. The reason why these are high-risk areas because we're looking at key vessels that eventually anastomose with the central retinal artery. So typically, the high-risk zones are the nasolabial fold. We already have the facial artery and angular artery, and for lip area, have the superior labial artery. For the nasal area, we have the dorsal nasal and angular artery and lateral nasal artery. So these are high-risk areas that we need to be super careful and be well-versed in anatomy. But bottom line, tissue damage can occur anytime you're injecting the head and neck area near a named vessel. So again, while we don't have a lot of time to talk about how complication and injection safety, I do want to mention some of the key pearls that may help you to minimize complication. It's important to understand injection mechanics. Whether you use needle or cannula, do not have a false sense of security with the size of the needle or cannula. It's important to understand rheology. When you're working with a thicker product, you have inherent higher risk because thicker products require higher exclusion pressure. And you may even get false negative aspiration with thicker product. And it's also important to be mindful of various techniques that can improve safety. For example, I like to inject slowly with the lowest extrusion pressure as possible with the smallest incremental volume as possible to minimize occlusion or bruising. A lot of times I keep the tip of my needle or cannula dynamic as I deliver the product. And when using cannula, when cannula is perpendicular to the major vessels, you may have a lower risk, but nothing's a guarantee. So this is why it's important to have a rescue kit in your clinic, hyaluronidase, aspirin, a sildenafil, and a referral network in case of emergency. So now let's move on to the fun part. So tonight we'll be going over some pearls for lip filler, under eye filler, and jawline contouring. So these really are among the top 3 requested procedures in my younger patients. Without saying lip filler is definitely one of the top procedures for any aesthetic providers. It's probably going to be as popular as neuromodulator. Especially for younger patients, lip filler is really sort of the gateway procedure into aesthetic arena. So here, when we look at lip anatomy, we need to pay attention to superior labial artery and inferior labial artery branching off the facial artery. This is an important landmark to note. Facial artery travels deep to the rhizoris and the zygomaticus major, about 1.5 to 2 centimeters lateral to the oral commissure. So you have to be super careful about this landmark when you're working near the lips with the nasolabial fold. And when you look at the general pattern of the superior labial artery, you can see that it travels typically between the orbicularis oris and oral mucosa, but above the oral vermilion, but it dips down below the vermilion as it approaches midline. So this is why when in treating the lips, it's important to stay submucosa, anterior to the mucosal muscular interface, and as you move towards the central portion of the vermilion, you have to be even more mindful of the location of the superior labial artery to avoid complication. So in my practice, I like to use both cannula and needle to achieve optimal results. Cannula, I typically use a 27 gauge cannula with a lighter product for a better outcome for hydration, maybe a thicker product for projection. So here I use cannula entry point about a centimeter or less lateral to oral commissure to avoid that facial artery. And also I'm able to treat both upper and lower cubicles with the cannula. And then other times I'll finish up the procedure with needle. Here is a video showing the tinting technique using needle to improve height and projection. Notice the level of injection. So it's very superficial, just below the mucosa to avoid complication. And as you're injecting lips, it's always good to be very vigilant to watch signs for occlusion. As for patient comfort, pain is oftentimes an indication of potential occlusion, followed by pallor, followed by sometimes change in the skin. The skin may become blotchy erythematous. So always be careful about what you're seeing as you're injecting the patient. While lip filler is not necessarily difficult to do, it takes a little more time and effort to be great at it. And doing a great lip filler will definitely be very valuable for you to retain that patient. A lot of times they will come back asking for other procedures once you give them a beautiful enhancement of their lips. So here, I want to advocate for details. Details is very important. When we treat the lips, we're not just treating the tubercles of the upper and lower lips. We're treating also the vermilion border, upper and lower. We're treating the oral commissure, make sure it stays a little bit perky. We're treating the cupid's bow to give a little bit more definition, crispier shadowing. We're also treating the filtrum when it's appropriate. It's important to also manage expectation, explain to patient what to expect. And I like to limit to about 1 ml of lip filler per session to avoid complication. And as I mentioned at the very beginning of the talk, it's important to assess patients' results both in static and also in dynamic movements. So you want to show them how their lips look not smiling and how their lips look smiling. And when they smile, a well-done lip filler should look hydrated, even, and not lumpy or uneven. And it's very important to show pictures to a lot of times patients may become fixated on one little area. They forget the global picture. So have a good before and after can really help you to maintain your expectation of the patients. And as I mentioned earlier, using cannula can minimize bruising, and it's important to be as gentle as possible, especially for patients are busy, younger patients particularly. They don't like to have downtime. They want to keep going with their life. So when you do a lip filler well and a patient walk out of your office with minimal bruising, they're very appreciative. These are before and after taken right after injection. And lastly, I want to comment on profile and balance. So when you look at lip filler results, you want to have not only a harmony on the front view, but also the side view, focusing on the projection and proportion of the upper and lower lip. As you can see, sometimes by focusing on the upper lip or the lower lip, you can actually improve the nasal mental angle and really improve the overall lower face proportion. And be mindful of patients' facial features as well. As you can see, this young patient on the left, she can carry fuller lips. That's why we use a more of a tinting technique to give her projection or height. While patient on the right, she has naturally more petite lips. So we're just focusing on hydration. And just a little bit of hydration actually significantly enhance the harmony in her face. I do want to comment that while we are going to do more lip fillers in the near future, but also going to treat more overfilled lips. This is something you need to be prepared to manage in your practice. Overfilled lips, here as an example, here you can see lumps or nodules or tendril effect from improperly placed filler material. And this is another example of overfilled, poorly filled lips. So be ready to have hyaluronic days dissolve and start over. It's important to educate patients on that. Now, moving on to under eye filler, this is another very desirable procedure. In fact, a lot of my young patients come in requesting under eye filler where they have never had any other procedures. This is because a lot of younger patients are seeking that natural, but quote unquote, filtered look. So they want to wake up looking fresh. They don't want to have to put a concealer on. They want the under eye area looks bright and rested. Oftentimes, we have more of a hereditary under eye circle in the younger patients where they have a deeper nasojugal groove as a hereditary tendency. They may have suboptimal infraorbital fat paths that lead into the hollowing. So when we talk about under eye filler, it's very important to understand the key anatomical landmarks. So here we have laterally a palpebral malar groove, which coincides with orbital retaining ligament. And then medially, we have the natural tear trough, which is actually a very natural landmark. You don't ever want to overfill the tear trough. The tear trough extends to nasojugal groove, which coincides with the zygomatical cutaneous ligament, and then extends further down to the mid-cheek junction. And then between the mid-cheek junction and palpebral malar groove, you have the malar mound. This is where you may see festooning in older patients or poorly done tear trough patients. When you select tear trough patients, it's important to pay attention to their skin quality. And it's also important to discuss expectation. I like to emphasize the importance of undercorrection when you're working in this area, because over time, whatever you inject in this area tends to hydrate slowly over time. So when patients leave your office perfectly filled, on the day of a tear trough filler, they may come back complaining of swelling or puffiness. And I like to limit to 1 ml of filler per treatment for both eye. And it's also important to pay attention to the mid-cheek complex and treat that necessary. So I'm going to share some videos going over pearls of under eye filler. So I typically use cannula. So this was actually filmed during the height of pandemic. I was still wearing a face shield and N95 mask. Using cannula gives me a much more freedom and maneuvering over the nasojugal fold. I don't inject more than 0.1 or 0.2 ml, depending on the patient. And now I move on to the lateral canthus area to reach the palpebral malar groove. This is a very important area to treat. So important to combine both medial nasojugal fold and palpebral malar groove when you treat the tear trough area. And then a lot of times when you use cannula, it's a very easy procedure to patient tolerate, and they literally walk out of the office and go back to their normal life. It also decreases the risk for bruising and discomfort and pain later on. Okay, good. The reason why tear trough filler or infraorbital hollow filler works because by softening that transition between the lower eyelid to the cheek, you can change the light reflection. So this is untreated side, and you can see the shadowing here, and this is the treated side. And when you select the right patient, tear trough filler can be very satisfying for patients of all age range and all skin color. And men are also becoming more interested in tear trough filler. A lot of my male patients come in, again, never had anything else. They just want to correct the appearance of the dark under eye circle. And lastly, I want to share with you the progression of under eye filler as illustrated by this patient. So this is immediately after a total of 1 ml HA filler. Here we use Refine. And you can see 6 weeks after, she looks even more hydrated. So this is why we tend to underfill, never overfill or avoid filling perfection when you treat the infraorbital area. This is the example my patient showed earlier this talk. So we had tear trough filler done in 2018, and we did another session 2020, and we did our third session 2022. And it shows safety of long-term tear trough filler. lastly, I want to conclude by showing you how to optimize your jawline contouring, which I really think is becoming the new lip filler, especially in younger patients. Jawline contouring has been fueled by social media as we're seeing transformation of our favorite celebrities. Patients are coming in asking for that chisel, snatch, contour jawline. Because that's really considered the current beauty standard. As injectors, we have a lot of tools in our toolbox. We have deoxycholic acid, we have neuromodulator, we have filler, biostimulator. It's important to treat the whole lower face when you talk about jawline contouring. Typically, I like to include chin, submental, and jawline to improve projection, proportion, and definition. So let's start with submental fat reduction. Here, using deoxycholic acid over 2 or 5 sessions, depending on the volume need to be reduced, you can significantly chisel the jawline contouring for appropriate patients. Typically, this works really well for younger patients. Even men are becoming more interested in jawline contouring. This is a before and after 2 sessions of deoxycholic acid. But for some patients, they don't need less, they need more. So here we're using hyaluronic acid to improve chin volume and projection and length to give that more contoured, more harmonious lower face profile. This is a patient using just 1 ml of hyaluronic acid. And the ultimate goal is to improve the nasal mental angle by improving chin projection and length. And I like to use cannula when I treat this area. So because cannula allows me more flexibility, more coverage, and also improve patient comfort. Again, here I'm using a thicker product to achieve more contour look. I like to usually treat both the pre-jowl sulcus, the chin, and then jawline to achieve the final results. And it's important to be flexible, customize the product selection volume based on gender and desired outcome. So for male patients, I like to use a more robust product. In this case, we used calcium hydroxyapatite CAHA radius. This is a photo taken midway through the procedure. This is the treated side. This is the untreated side. We used a total of 3 ml CAHA in this case. As you can see, it's a more masculine look, it's a more chisel look, it's a stronger jawline, which fits what the patient desires. I do want to call out that it's important to not over-masculinize when you treat lower face or jawline area. This is not what we want to aim after in our before and after. That very sharp chisel look oftentimes is photoshopped. So we need to explain to patient about what realistic expectations are. Again, we want to be very careful about product selection and quantity. And then lastly, I want to conclude by showing you some before and after using combination treatment. This is a combination of 3 sessions of deoxycholic acid to slim the submental area, followed by injection of hyaluronic acid to improve the chin and jawline contour over time, 6 months time. Sometimes patient may benefit from a combination of jawline filler and lip filler to give a more harmonious lower face. And then in stronger patients, particularly in your Asian patients, they may come in wanting to have a more of oval shape, so we can transform the patient shape by using master botulinum toxin, chin filler, and deoxycholic acid in this case. This is just a quick video showing you how to perform masseter Botox. I had to treat the posterior, anterior, and superior aspect of the masseter muscle using a 30 gauge needle that allowed me to go deeper. Sometimes we'll treat the temporalis muscle as well when they have TMJ. And lastly, as I said, whenever in doubt, say no. And also try to undercorrect and then overcorrect. So this concludes my pearls on practical approaches for aesthetic procedures in the younger patients. We will then gather together for the final section